Very good afternoon and a warm welcome to one and all present here in this session. I am Debolina from Clearnet and we are very much proud to be a part of this webinar as a digital partner. Clearnet is India's largest live digital CME and a doctors generated medical content platform which is exclusively free for all the medical practitioners. So now with all of you, I am going to share a short glimpse of Clearnet. Thank you so much, all the doctors, for your patience. Our website goes www.clearnet.com. There we have lots of live sessions conducted by eminent speakers across the globe. We have MedWiki services, which is medical Wikipedia for doctors only. That also you can read in your leisure time. So now, without further delay, I'd like to hand over the session to Dr. Prashant Karia sir to start with our today's session. Over to you, sir.
Thank you so much. On World Prematurity Day, I, Dr. Prashant Karia, Secretary of NNF Gujarat, welcome one and all to today's panel discussion. I request our President, Dr. Sandeep Trivedi, to welcome one and all.
Thank you, Prashant. I welcome our colleagues, all the pediatricians who are joining with this network, Neonatal Pathshala, and this is the very popular program. So routinely we done on the Wednesday, but today prematurity day, so we take this Pathshala program on the Thursdays. And I also welcome all the panelists and the moderator, Dr. Manan Parikh. Thank you very much, Prashant. Hand over.
Thank you so much. So as we all know, today is a World Prematurity Day, and around 1 in 10 newborn is born as a premature. There are so many causes of prematurity and there are so many complications. There is so much to learn about the prematurity. And if we master about it, there will be a better outcome, a better intake survival of a newborn. To learn all this, today we are having a panel discussion, which will be moderated by Dr. Manan Parikh. Manan Parikh is a neonatologist in Lotus Hospital, Baroda. He has done his MD from Baroda Medical College, MS University, Baroda, and fellowship in neonatal medicine from Kokilabin Dhirubhai Ambani. So I welcome Manan, who is a very good speaker, has taken many talks in state and national conferences, and also a co-author of the book Point of Care Neonatal Ultrasound. Welcome, Manan. Please introduce your faculties and start. Thank you. Manan, unmute.
Thank you, Dr. Sandeep, Dr. Prashant, and NNF for providing this wonderful opportunity to talk about for tiny babies and how can we help them for their better life ahead. So let me share my screen. I hope my screen is visible.
Yes.
Yes.
So today's session is about parents embrace a powerful therapy for any kid, especially for preterms. And for this discussion, we have our good friends and good neonatologist, a young neonatologist working in different areas of Gujarat with us. First of all, we have Dr. Snehal Patel from Ahmedabad, Dr. Deepen Patel from Karamsad, Dr. Kunal Aya from Rajkot, and Dr. Hitesh Patel from Surat. As we know that we are celebrating this World Prematurity Day, and Dr. Prashant already told that 1/10 of the babies delivered are preterm. So the burden is huge. And we will see what is the problem of this preterm, what we can offer them, and how we can provide them better opportunity for their better future. And for that, we have devised this question answer format with help of my esteemed faculties, panelists here, and we will discuss how we can help this preterm. So first, I would like to ask Dr. Deepen that what is the exact burden of this prematurity around us, and why these prematurity rates are day by day now rising around us. Dr. Deepen.
Yeah. Good afternoon, everyone. Thank you for inviting in this global talk. So the question is, what is the burden of prematurity? We all know that in our NICU, around 50% of the newborns are premature. If you look at this world map, in which India is a little bit dark blue, which is around 10 to 14% of the preterm birth happening in our country. So globally, the birth rate ranges from 5% to 20%. In certain centers of our country, which are caring for tertiary care complications like preeclampsia, eclampsia, in such centers, even the birth rate of premature newborns is more than 20%. If you want to compare the population wise with our nearby country, China, which has the highest population in world, but the contrary is that despite the highest population in China, their number of or proportion of preterm birth is less than half than our country. And our country contributes to the highest number of preterm births. And this is the report of 2012. You can go to next slide. Some of the factors which may increase the risk of preterm births are very well known, like maternal malnutrition, maternal anemia, poor care, or infrequent antenatal visits are one of the factors which will increase the rate of preterm births. Some of the factors like adolescent delivery, less interval between the two pregnancies, consumption of tobacco and other abusive drugs is also one of the important contributing factor for preterm births. Now we must have noted that the diabetes in pregnancy is rising. Even we have also seen that the proportion of mothers having hypertension or hypertension disorders in pregnancy are rising. These can be the factor of increased rate of preterm birth globally. Yeah. Next.
Right. So around us, as Dr. Deepen said, there are lot of changes happening the way we are dealing with our patient pool. And just to summarize, in India, we are having 36 lakh preterm deliveries a year, and which contributes to 25% of the global preterm population. Just imagine, 1/4 of the global preterm population is in our country. And just to break it down, like we have 3 lakh preterm deliveries every month, or we can say 10,000 delivery per day preterms, or by the end of our talk, after 1 hour, we will be having 400 extra preterm babies with us to treat with. And that is why this burden is huge. Just imagine, per hour we are having 400 patients in our country who are preterm and who need to be taken care properly. So this 400 patients every hour with us, Dr. Hitesh, if you can elaborate, what are their problems, what problems they have in all the fronts of their life? Dr. Hitesh, please.
Hitesh, unmute.
Okay, fine. Thank you so much, Dr. Manan. As he has rightly pointed out in previous slides, that there are the chunk of these preterms babies are nowadays increasing. So we are very much aware that this preterms baby has immature organ system. So in immediately after birth, we are facing different problems to deal with this premature baby, like because of immature respiratory system, GI system, immunological system, hematological system. So these babies faces a lot of the problem immediately after birth. But apart from this immediate problem, if we think that nowadays, because of improvement in our neonatal care, because of improvement in quality of neonatal care, nowadays, the survival rate of these preterm babies are increasing day by day, annually. So if we think about the long-term aspect, so these premature babies are facing a lot of the problem in long-term lifetime also. So different kind of long-term problems that these preterm babies are facing, like right from the early infantile age, then in early childhood age, then teenager, adolescent, adults. If we understand that immediately after birth in early infantile age, these babies are having some issues related to developmental delay. That can be range from mild to moderate motor impairment to the severe impairment like cerebral palsy. This baby faces the problem with sensory impairment like hearing impairment to deafness, some problem with the visual impairment like that ranges from different kind of refractive errors to blindness, and also some problem with some language disorder, dyslexia, all these things. Some problem with the socialization these babies are facing, like autistic disorder. Once the baby moves towards early childhood age towards the schooling, they faces the problem with some academic performance, some behavioral problem, some hyperkinetic disorder, attention deficit hyperkinetic disorder these babies are facing. Again, all these things makes them poorly perform in academic tasks. To go further in adolescent adult group, these babies faces lot of emotional problem. What we are seeing in nowadays in our society, like they stress induced depression, anxiety disorder, all these are linked very well with the prematurity also. So all these psychological disorder, emotional disorder, behavioral problems, all are that can be linked with the prematurity. And because there is an increasing burden of these premature babies, we need to focus on this domain so that the early intervention, early identification of these things can be done and we can help them out. Also, not only this physical and psychological problem, but because of some family that is in some family, if they are having some premature baby in them different life years, they are also facing a financial burden because these babies requires repeated hospitalized care, repeated medication cost. So all these can affect the psychological as well as emotional aspect of family members too. So we need to focus on this domain, not only just our role of we are. It's not like that our neonatal care has completed all these all these things, but we need to focus on the follow-up of this group of the baby also.
Great. So as Dr. Hitesh said, these babies are very premature. Their organ system is very immature, and that is why they come with the problems, immediate problems. And the most important thing, the brain is delicate, and we don't know how this brain will grow, and there are a lot of interference to this growing brain, which will ultimately affect the life of the baby in the later life. So now we know that we have a great chunk of the preterm babies with delicate brain who can have greater problems in the life. So I want to ask Dr. Kunal that to care for such delicate baby with a delicate brain, what are the advances in neonatal care, especially during last decade has happened for caring of such delicate preterm and extremely low birth weight babies? Dr. Kunal, please.
Yes. First of all, I would like to thank you, the organizing team, Dr. Prashant and Dr. Sandeep, for giving the opportunity to present on this World Prematurity Day. As we had seen that the prematurity rises, there are many complications are there. So are the advances which have been brought forward and are helpful to prevent the prematurity as well as help treat the premature and ELBW babies. So first what we see is, first of all, we had seen that in the last decade, we have got a new definition in the preterm babies also. That previously any baby is less than 37 weeks was just called preterms. But there is a classification of late preterm also between 34 to 37 weeks. So in those babies who are having weight of more than 2 kg were preterms, were not catered for very well. So now they have been specifically classified and they need to be monitored specially, and they are having problems like respiratory distress, hypoglycemia, neonatal jaundice. All those problems are happening in this special category of babies who are not being looked after because they are just looking well or having a good weight. So first thing is that they have classified. Second thing is that what we need is an intact brain in these premature babies. So for that, neuroprotective strategies have been applied. So magnesium sulfate, antenatal magnesium sulfate therapy has been used by the before delivering, is being given to the mother for the neuroprotection of the babies. And antenatal steroids has been used since long, but it has shown strong evidence, and its use as is being one of the most significant drug, which is helpful in preventing RDS, IVH, NEC, and all. Treatment modalities are also improving in babies, like CPAP is coming in a big way. In the last decade, we had seen that surfactant had come in a big way and ventilatory strategies were there. But nowadays, gradually, we are shifting from invasive to more and more non-invasive ventilation. So what we are doing is we are giving delivery room CPAP to the babies, and with that, the use of ventilation has been reduced significantly, as well as the use of surfactant has also reduced significantly, because CPAP itself opens the lungs and induces the production of surfactant, endogenous surfactant. So because of that, the use of ventilation has also reduced significantly. More and more preterms we are able to survive with this kind of strategies. Use of caffeine citrate. Previously we were using aminophylline for prevention of apnea of prematurity, but since last few years caffeine citrate has come up, and it has less and less side effects are there. Then again, for intact survival, developmental supportive care is also being used, that we'll be talking later in the talk, but that has also come up in a big way. Kangaroo mother care is an integral part of the developmental supportive care, and since it has been used since 1978, but still more and more evidence is being come up, and it has been it is very helpful for the babies, and especially for the development of the brain and overall growth of the baby. Yes.
Okay. So, as Dr. Kunal said, from the definition of prematurity, the whole therapy spectrum has changed. And why this has changed? Because our outlook towards this preterm has changed. As a treating person, our outlook towards the preterm has changed. So I would like to have views of Dr. Snehal Patel, that when we are carrying a preterm, what exactly are the aim of the treating these tiny babies? Dr. Snehal, please.
Yeah. Yes, sir. Hello.
Yes, you are audible, Snehal.
Yes. So first of all, I would like to thank Dr. Prashant Karya sir, Dr. Sandeep Trivedi sir for giving me opportunity on this World Prematurity Day to to be a part of this panel discussion. And yes, so as we have seen, Manan, we are seeing that the preterms are because of increasing the preterm delivery, the global burden of the preterm and the morbidities related to that is increasing gradually. But our aim as a neonatologist is to ensure an intact survival of this all preemie babies. And rather than giving developmentally challenged or handicapped kids to the society, our aim is to give intellectual kids to the society. So that should be overall, aim of a neonatologist should be there. And for that, I would say the our immediate goal should be taking care of all aspects of the prematurity, and where we can increase the neurodevelopmental outcome of these babies. So if we discuss about the respiratory care, we are gradually moving from the invasive support to the non-invasive support and a more physiological support to these babies. We aim to prevent a hypo or hyperoxia to the preemies, to avoid fluctuation in the cerebral circulation, and that will help us to get good cerebral circulation in these preemie babies. We should avoid ventilator associated lung injury, and that's why we should be getting less babies with the BPD, bronchopulmonary dysplasias, and the prolonged respiratory support of these babies would be curtailed accordingly. And early weaning from the invasive to the non-invasive support, and from the non-invasive support to the room air should be our main goal in taking care of the respiratory elements of these babies. For the GI, as we all know, early enteral nutrition has been proposed, and we all know the benefit of the same. It enhances the brain growth of the baby. It increases the intestinal maturity of the babies. It gives a good microbial flora to the intestine, so it will reduce the chances of neck and all in these babies. We should give a proper nutritional support, and so that we should avoid extra uterine growth restrictions in this baby, so that these babies do well in the future, physically and mentally both. Neuronal support is main part, and we should give a developmentally supportive care to avoid any kind of fluctuations in the neural pathway. So then taking care of temperature of the babies, taking care of apnea of the babies, then giving a proper nesting to the babies in a developmentally supportive way. Kangaroo mother care, as we know, all the benefits of the kangaroo mother care. So this should be an immediate goal and aim as a neonatologist should be there. So to give a holistic developmental care to the preterm babies. The late sequelae of these babies, we know it's an ROP, retinopathy of prematurity, hearing deficit, and the metabolic issues in the form of osteopenia of prematurity and all. So that this baby should be screened regularly to prevent any kind of future problems in the form of blindness and all. And laser and Avastin should be injected whenever it has been required in these babies. And the future plans, future aim of these babies is to we have to screen the babies every third monthly for the neurodevelopment elements. From the NICU, we do amyltecin or amyltecin or the Bailey scaling, and this Bailey's should be followed regularly to see there's any deviation in the behavioral or the developmental element of this babies, and should be taken care of accordingly.
Fine. So as Dr. Snehal said, there are array of interventions to ultimate goal of providing intact survival. But if we want to summarize this everything in a single sentence, I would say that we want to create an environment as the baby was in mother's womb, and that is how we can curtail all the problem. So I want to ask Dr. Deepen to elaborate us on what are the evidence-based intervention that will ultimately help to improve the outcome of this delicate premature babies. Dr. Deepen, please.
So if you want to divide this into two parts, like you can have kind of antenatal and intrapartum interventions and postnatal interventions, because prevention of prematurity is one of the important factor in taking care of newborns. Several studies has been done with regard to preventing prematurity. Some of the studies, like even caring of the oral hygiene, may also help. So such several studies have been done, but for our population, Indian context, social and cultural factor, if we consider, one of the important antenatal intervention could be counseling on healthy diet, because we already know around more than 50% of the population are anemic in antenatal period. So ensuring optimum nutrition and avoiding tobacco and substance abuse will help to some extent in reducing prematurity. Other interventions like diagnostic tests, like using ultrasonography in antenatal period, measuring fetal growth to understand whether it is a single fetus or multi-fetal gestation, will help minimizing the risk during the pregnancy. Using ultrasonography during third trimester will help using early intervention, whether we want to now do early labor or not. Other important thing, still we are struggling with the optimum antenatal visits. At least 8 visits are recommended to improve the outcome in terms of identifying risk factors, and which will help reduce preterm related complications. If mother has come in a preterm labor or there is imminent risk of premature delivery, we all know that using antenatal steroid will reduce risk of mortality, intraventricular hemorrhage, NEC, and future neurodevelopmental outcome. Even we also know that if the mother is expected to be delivered before 32 weeks, using magnesium sulfate will reduce the risk of neurodevelopmental disability. Even to certain extent, using tocolytic agents may help extend the gestation by a few weeks. So in this way, we can help manage the premature delivery. If you consider the factors which we can do after birth as a kind of intervention, WHO has recently launched a manual of care of preterm and low birth weight neonates as a part of this prematurity day only. So they have divided these interventions into 3 categories, as you can see here. One is preventive and promotional care, we have already discussed. But after birth, kangaroo mother care, they have specifically emphasized because it has found to reduce mortality by some extent. Thermal care, mother's milk only will further reduce the risk of mortality and morbidities in newborn. Now, we also know that donor milk is the option we have, but mother milk is the best option for taking care of a preterm newborn, especially when they are less than 1.5 kg. If you take care of a baby when they are sick, like optimally utilizing CPAP will reduce the risk of need of intubation, surfactant, and using methyl gensins has also been shown to be beneficial, as already Dr. Hitesh has said. It reduces the apnea, and it has been found to reduce bronchopulmonary dysplasia and other morbidities as well. Now, family-centered care has come up in a big way, and WHO has recommended that utilizing family-centered care to some extent only, it will help reducing several complications in a birth baby, like it will improve the birth weight of it will improve the weight of the baby, improve the length gain. It also reduces the risk of intraventricular hemorrhage. ROP also reduces and also improves the neurodevelopmental outcome. Though it has not been found to reduce mortality, but these morbidities, when they are reduced, it certainly help the family in managing the preterm newborn. Over to you, Dr. Manan.
Yes. So there are a lot of evidences behind now preterm care, and from the evidences from our experience now, there are two major shifts in the treatment of this preterm that we have observed. One, we are moving from invasive to non-invasive interventions as far as possible according to the clinical condition of the baby. And second thing, we are expanding our team, and the new team member are the family members, the parents of the baby, and they are the must to have the proper outcome of this preterm babies with us. So let us see now that we have a parent. Due to some complication, they are expecting a preterm birth. An obstetrician is worried, relatives are worried, and the obstetrician has sent this patient to you, Dr. Snehal, for antenatal discussion. So how will you involve these parents? How will you counsel these parents for the imminent threats and for long-term outcome? Dr. Snehal, please.
Yes, Manan, thank you. So basically nowadays, as we are expecting a preterm deliveries with this baby, we should involve the parents as a core member of a team, because we are going nowadays more and more into a family-centered care for the NICU. So the parent should be a core team member for any kind of it should be integrated decision making involving the parents at any point of the time of some critical decisions. And at the first point, we should counsel them considering the prematurity, the gestational age, the weight of the baby. We should explain the morbidities related to this prematurity and the mortality as well, and taking them into the confidence for any advice related to prematurity in the form of respiratory care which we are going to give to the baby, their readiness for giving a KMC to the baby. Later on, we can involve them in the feeding when we are with the feeding, we involve the parents, how we are preparing to feed, or how to explain the mother how to express the milk out, how to store the milk, and how to bring it to the NICU. This all things we have to discuss. We have to prepare them that this baby is not matured in matured in any system, and this NICU care would be involving the support in all the elements of the in form of respiratory, nutritional, GI, the neuronal. In all this aspect, we should explain the related morbidities of this preterm babies and involve them into the care of the same. There are many trials for the NICUs, and one of the trial has been HOPE trial, that is creating opportunities for the parent empowerment. And in that, they've seen that incorporating the parents into the rounds as well, in the NICU rounds as well, have improved the parents' compliance to the treatment and the baby's outcomes as well. So yes, we should involve them as a team member.
Right. So as Dr. Snehal told, involve them as a team member, explain them everything. Another important thing that I want to stress here, that whatever we explain, whatever we talk to them, just write them and take this sign, because these things are now coming to the legal criteria also, that these parents have been explained properly or not. It is not like that obstetrician find a complication, they tell parents that go to the OT and take out the baby. No. True. The counseling part is legal binding. So we have to explain them everything and then put down the notes of everything. And then
I would like to share that, Manan, at the time of discharge as well, the whole checklist should be given and to be maintained by in our record as well as the parents' record. For the ROP visit, for the neurodevelopmental follow-up visit, everything it should be mentioned properly and countersigned by the parents.
Yes, great. So these parents were expecting a preterm birth. Dr. Snehal has beautifully explained them everything. Now, this patient is in delivery room, in operation theater, and Dr. Hitesh, you are called for this delivery of this preterm baby. So what measures will you take that can help to ensure the developmental supportive care apart from routine NRP and resuscitation? What are the other measures which we ensure at delivery in labor room? Dr. Hitesh.
Fine. So basically, we all know that there are many things in a neonatal resuscitation program which have a very much positive impact in improving the long-term development, like regulation of temperature, delayed cord clamping, establishing a breathing immediately after birth or as soon as possible. All these things have a very much positive impact. We all know that, and where all the studies have proven. But apart from all these measures, some basic or many minor things are very much important. And what we are repeatedly talking about these things like family-centered care and some very basic things like providing a skin-to-skin contact as soon as possible immediately after birth. Means if the baby is full-term, if there is a spontaneous breathing, having a good muscle tone, then keeping the baby on the mother's abdomen and providing the mother's warmth, it helps to establish the temperature in normal range. It also improves to establish, it also helps to establish breastfeeding as soon as possible, as early as possible within 24 hours after birth. Also, it improves the bonding of mother and baby, and that helps to reduce the psychological stress of mother also and other thing also. Apart from this skin-to-skin contact will help to improve the transition phase physiology also. What we are seeing in many premature babies, especially in late preterm baby. So this basic thing will help for the improving the cardiovascular health also. So apart from this skin-to-skin contact, another thing that is the family-oriented. Our approach should be the family-centered care. It means that we need to involve the mother, father, other family members. We need to counsel them properly, as rightly mentioned by Dr. Snehal. We need to train them. We need to emphasize some important aspect of basics need of preterm baby, what actual or basic care these preterm babies needs, what is the importance of exclusive breastfeeding, and we have to provide the emotional supports to mother that can help to improve this breastfeeding part also and to take care of the baby confidently also. Apart from this, another thing I want to highlight, there is a terminology, developmental bundle care. So there are many things. We know that uh, there is not a single thing which can improve the neurodevelopment outcome of a preterm baby. So we need to think about the multiple approach, multimodal approach, or multiple things that can be bundled, just like that can improve or that can have a positive impact in long-term neurodevelopment of this premature baby. So those things are like positioning of the baby, keeping the baby in a supine position when the baby is sleeping, keeping the baby in a prone when the baby is alert, or on the sideline position. Also, the baby's limbs should be flexed in a way that the baby is just keeping the position inside the womb of the baby. So that can be achieved by nesting or keeping the boundaries or by the bundling. Another thing, like avoid the excessive exposure of light in a room. The light should be like dim light exposure in a daytime. There should be a circadian or varying degree of the light exposure that can help to improve the circadian rhythm of hormonal system of the baby also. Avoid excessive noise rather than providing a soft music therapy or the soft singing by the mother can help also stimulate the baby's sensory cortex. Swaddling the baby while holding the baby, gentle human touch or massaging a baby. Also, take care of the baby sleep also. Avoid excessive disturbance or discomfort while baby is sleeping. So all this can be termed as a developmental care. So all these things we are having on single modality with that includes all these multiple things in a single with the help of the single modality, and that is the kangaroo mother care. So a kangaroo mother care, the art and science of the kangaroo mother care, we all are knowing. And with the help of kangaroo mother care, keeping the baby skin to skin contact, it will stimulate tactile, it will give the tactile stimulation to the baby. By keeping the baby swaddled in between the breast, it will improve the sensory stimulation. Also, promoting the baby by keeping in the KMC position for the breastfeeding, that will help to establish the breastfeeding rapidly. While feeding the baby, that will also stimulate the olfactory and gustatory sensation also. So I can say that the kangaroo mother care is an holistic approach, or it's a multiple sensory modality that can, with the help of that, we can achieve all these goals maximally. So we need to encourage mother more and more. We need to give emotional support, and also the mother needs the support from family member, community, and also the healthcare personnel. So we should advocate this therapy in our delivery room, starting from the delivery room only.
Right. So delivery room with the preterm babies, what we expect is as soon as possible, give the baby to mother and start skin to skin measures. Second thing we don't forget here, and now this NRP also advocate the delayed cord clamping. When we are talking about holistic approach, when we are talking about a minute and smallest intervention that will help the child in later life, even if we are having preterm child, we should not cut the cord immediately, and we should advocate the delay cord clamping. And as you can see in the picture here, there are now equipments and trolleys available. This is like Lifestar, which is available and which we can keep near the delivery table. And as soon as his baby is delivered, we keep the baby on this. We keep the baby here on this trolley with the cord intact. Even if we are requiring resuscitation, we can do resuscitation here. And then the benefit of delayed cord clamping can also be given to the baby. Now we have delivered this baby. Now this condition is of the baby is not that critical, that is not requiring any NICU admission, or it is a stable preterm. For basic care level 1, level 2 NICU care, this baby is admitted to the NICU. Dr. Kunal, if such babies are with you at your NICU, what are the immediate postpartum period measures that you explain and advocate your staff and parents to ensure, execute, and encourage KMC and developmental supportive care? Dr. Kunal, please.
Yes. See, as very well explained by Dr. Hitesh about the developmental supportive care, and KMC also is a very integral part and a very important part of the developmental supportive care. So basically, developmental supportive care is the main. This thing is to reduce the stress and the promote the growth of the preterm infant. So from the word go, we have to start explaining to the parents about the KMC, as Dr. Snehal had explained. Even before birth, in the antenatal counseling, we should be explaining to the parents about the kangaroo mother care. After birth, immediately, if the baby is stable, as we had mentioned, then we should start the KMC as early as possible. Our staff should be well trained and very supportive to the parents. Involvement of the mother as well as some other family member who can give support to the mother also should also be allowed in the NICU and should be there, be present at the time of giving KMC to the baby. KMC should be started as early as possible. Their first 1 or 2 sessions should be very elaborate and in detail explaining about the position, the benefits of the KMC to the mother and to the relatives, so that KMC has to be started in the NICU and is to be continued when the baby is discharged to the home. That is very important. Two main components of KMC are that it's skin to skin contact for as long as possible, minimum session of 1 hour, and it can be extended for 24 hours a day also. KMC. And second thing is the position or positioning or the procedure of the KMC. The baby should be positioned in between the breast of the mother. The baby should be wearing caps, mittens, and socks and diaper. It has to be positioned prone. The position of the mother should be semi-reclined position. 15-degree position is a good position for the mother. Either KMC chairs are available or even pillows can be used to position the mother so that she is comfortable. Then the clothing of the mother should be, she should be wearing a front open gown or even blouse or shari could be worn. She should be lying, then some staff should be helping her to position the baby. Initially, she would need help and support also, and positive feedback also regarding KMC. Afterwards, when the mother is confident, she individually can do it. When the mother is not free, then some of the relative like dadi, nani, grandfather or father can provide KMC to the baby. While providing KMC, we should take care that the head of the baby is turned to one side and is slightly extended position. And like the natural universal flexion position, baby should be lying in a frog-like position. And then the bottom of the baby should be supported well. And there are special KMC dresses are also available. Or if it is not there, we can use binders also to support the baby. The mother can do her work also as well as can sleep while doing KMC also. So it should be done for as long as possible. So first step is it has to be started in the NICU and well explained. Support should be there for the parents and it has to be continued for as long as possible, and even after discharge also it has very shown proven benefits that it is helpful for the babies for better heart rate, better breathing, better weight gain, better growth and development of the baby. It lowers the cost to the society and it promotes the breastfeeding also very well. For developmental supportive care, there are 5 key components. Most of them is being explained by Dr. Hitesh, but 5 key components are: it has baby needs protected sleep, like in NICU after every some period of time once we are giving sugar, then we are giving feeds, then changing diaper. It has to be a cluster care so that the baby's sleep is disturbed at minimally. We have to provide a healing environment to the baby, like no unnecessary noise, no unnecessary disturbance to the baby. Avoid procedures as to be as minimal as possible. It has to be a family centered care. Parents care should also be involved. We have to support the daily living activities of the baby, and as well as we should take care that the pain management should also be there, and as long as possible we should avoid pain in the for the babies, and KMC is a very integral and important part of the developmental supportive care. Over to you, Manan.
Right. So baby is stable in NICU as soon as possible. As soon as the mother is available, we start KMC with whatever notations Dr. Kunal told. Now, another spectrum of the ICU care is we are dealing with very sick babies. Preterm baby is in ICU and is very sick. So, Dr. Snehal, will you give this baby KMC? And if yes, then how will you do it? How will you involve the stakeholders? Dr. Snehal, please.
Yes, Manan. So KMC has been now and very integral part of management of any of the preemies, whether it's a sick or a stable preemie. So in the sick preemies as well, if the baby is not on a ventilator, is on NIV support like in the CPAP or HFNC, I would advise to start KMC as soon as possible. And for that, the staff motivation is most important. So you have to prepare your staff, how to monitor this babies on a non-invasive ventilator or in the CPAP when you are giving the baby on a KMC, how to take care of the positioning of this babies well. So, ongoing monitoring would be continued. And at the same point of time, we can give a kangaroo mother care to the babies. And this would be a good point to involve the mother in the care of the babies as well. Like, if we are giving the baby with an IV support, and if there's a drop in the saturation, the mother will also, knowing that what is going on with the baby, and, she can be, involved in the care of the baby. So this is very important. So, I would say as early as possible, we should start with a KMC to preterm babies and sick preterm babies, and time is no bar. Minimum 6 to 8 hours of a KMC has been recommended, but it can be given for an extended hours as well. But as I said, your staff should be motivated. They should be ready to, to give a care, and their readiness is most important. And at the same point of a time, mother should be given a welcome environment when she is coming to the NICU. The comfortable chair should be provided to her. The comfortable gown should be given to her, so that she can stay there for extended period of a time. So yeah, as soon as possible, I would advise to start with the KMC.
Right. So even if baby is sick, even if preterm is sick,
yeah,
only thing that is hindering the baby from KMC, a little bit hindrance is the ventilated babies, because the tube and position of the tube.
Exactly.
And
so NIV is a good. Sorry.
Yes, hemodynamic instability and ventilatory support. Apart from that, everything else we can give KMC. And
Yes.
Here important, as Dr. Snail told, involving staff. Staff has to know each and everything. If the baby is on CPAP, if the baby is on high flow, how to handle the lines with the umbilical lines. And we in our ICU, we call a particular staff KMC champion. So that staff is responsible for all the KMC procedures in our hospital. She will empower the mother, she will empower the parents, she will train other staff, and she will look forward to the KMC as soon as we have admission in our NICU. So this is how we can ensure and involve stakeholders and can provide KMC in each and every baby.
Yeah.
Like this.
To add on this, we should add a KMC hours chart as well in our NICU vital parameters chart for the nursing chart. So how many hours a day the KMC is being given, that should be noted in that chart. That will motivate the staff as well as the mother to give more and more of a KMC hours to the baby. And to add on this, there are multiple studies to show the benefit of the KMCs to the sick preemie babies. And one of the study which has been recently published, it shows that the MCA flow has been markedly improved. The PI and RI has been significantly lower down, and the cerebral circulation has been markedly improved post KMC. They have done this, MCA flow 30 minutes before and 30 minutes after the KMC, and the results are very much overwhelming. So I think we should discuss all these details with our staff and then motivate them, to provide more and more KMCs to the sick preemies.
Perfect. So irrespective of the sickness of the baby, we can give KMC. And as you can see in these pictures, the father is giving KMC, the aunt is giving KMC, the mother is giving KMC, and all of them are happy. Remember, they have a big pain of having a preterm baby. They have a big pain of spending a lot of ICU expenditures, and still they are happy. And what are the things that make them happy is this KMC. So this is how we can do in ICU practice. Now we are doing the KMC in our ICU for all the preterm babies. Dr. Deepen, what are the benefits of this KMC and skin to skin measures to the mother and family of this KMC doing stakeholders? Dr. Deepen, please.
Dr. Anand, thank you. So now we all know that during 1970s and 1980s, KMC was innovated as a part of a alternative care for incubators, where there were least resources for taking care of low birth weight newborns. But as the years passed, we recognize there are several benefits of KMC, and these are the very few, I can say very few at this moment because of time constraint. But in summary, if you can see, KMC has been proven to reduce mortality of newborns. Even WHO has considered KMC as one of the important and priority care in which we can use for preterm and low birth weight newborns. And it has been found to reduce all cause mortality at discharge and at 40 weeks of post-menstrual age. The relative risk was 0.68 and the CI was 0.53 to 0.86. Thus, it has this several systematic reviews has surely said that the KMC is a benefit for reducing mortality. Usually, KMC has been used to manage hypothermia in cases. So we all know that hypothermia cases are nicely being managed by just providing KMC. We don't need a warmer or incubator for taking care of the newborns. Even sepsis has been found to be low in babies who have been provided kangaroo mother care. Not only the breastfeeding rates have increased, even exclusive breastfeeding rates have been improved with utilization of kangaroo mother care, which has ensured optimum growth and development of the newborns. Even some studies have shown that gray matter increases over the years in those newborns who had received KMC in earlier prematurity days. KMC has also been found to be useful to reduce hospital stay, and thus it might help in reducing cost or overall stay in the hospital. So it will also reduce financial burden over the family. We have seen that many newborns who are preterm, they are anxious to receive the mother. So KMC has been found to improve bonding between the families and the baby. It has been found to reduce the stress of the mother and newborn. And definitely, as we have said that we are now towards the concept of family-centered care, KMC is one of the priority area in which it will strengthen the family-centered care. There are other benefits to say, like it reduces the pain. So several studies have been done and found that KMC is one of the important component which can be utilized as a non-pharmacological measure to reduce pain in newborns. It also helps in reducing apnea of prematurity. So these are some of the benefits of kangaroo mother care. Over to you, Dr. Manan.
Yes. So the mother and family, this KMC helps to overcome the worries of postpartum period. It will improve the maternal emotional quotient and emotional health, and will ultimately help the family for the economical way of dealing with the preterm babies. Now, Dr. Kunal, can you elaborate the benefits of KMC, particularly to that preterm baby?
The
Dr. Kunal.
benefits, yes, the benefits of KMC to the baby are enormous. First of all, it helps the baby to breathe regularly, so the chances of apnea are decreases in the babies who are receiving KMC. It promotes the breastfeeding rates also significantly. So again, we know that breastfeeding itself has very many beneficial roles. So it promotes the breastfeeding. It shows that the baby has a chance of better weight gain is there in the babies who are receiving KMC. The bonding between the mother and the baby improves significantly. It helps to regulate the temperature of the baby also. And the baby who is receiving KMC sleeps better. So his brain growth is also more. The baby is more happier, cries less. Again, same for the mother's anxiety, and it also reduces to a significant level. So these are some of the important factors which are beneficial to the baby in the short term. In the long term, these babies will have higher IQ, better weight gain. So neurodevelopmental outcome in these babies is also more. So there are various stimulations, like as mentioned here, that vestibular stimulation is there because of the up and down movement of the maternal thorax. There is a better tactile stimulation. All the sensory inputs are more in these babies. The order of the parents, the milk order is also there. The baby hears the mother's breathing, the voice, the heart of sounds of the mother. There is a visual contact between the mother and the baby. And it when the mother is moving, it helps in even proprioceptive stimulus to the baby. So there are so many advantages of KMC to the baby. Over to you, Manan.
So ultimately, KMC helps the baby to grow well in ICU and to do well in future, and it stimulates all the neuro sensory systems, which ultimately help for the intact survival. So, Dr. Hitesh, just to have your idea, is KMC only for preterm babies?
In a single word, I can say no. This is not only just for the preterm babies. If we understand the art and science, what in the previous slide has been mentioned, and what is the main purpose or the main fundamentals behind the kangaroo mother care, and if we understand the various benefits of the KMC to the baby as well as the mother as well as in a hospital also, then we can say that that can be helpful not only just for the preterm but for all those babies, but particularly those babies with a low birth weight, less than 2.5 kg. In the category of baby with a birth weight of 1.8 to 2.5 kg, it is easy to start the KMC immediately after birth, as those babies are quite stable. But in a category of the baby with the premature or with the birth weight of 1.2 to 1.8 kg, or if we can say the gestational age less than 35 weeks, those babies are having some problems with their medical illness, like respiratory problem, cardiovascular problem. So once we need to have stabilization of those babies, and then we need to start KMC as soon as early as possible once the baby is stable. Particularly in an extreme low birth weight baby or less than 30 weeks or less than 1.2 kg birth weight babies, those babies are quite sick in initial few days or maybe for week. So once their hemodynamic status and respiratory status are quite stable, we can start the KMC. So to begin with, the KMC can be begin immediately after birth in a stable baby, continue the KMC in NICU, and then once the baby is in the postnatal side, we can encourage a mother for the KMC and to continue the KMC even after discharge also. And
Right.
as we know that the KMC has a very much benefit in terms of improvement of not just for the growth, but also it improves the long-term neurodevelopment of the development of the baby also. So we need to emphasize the KMC as much as possible.
Great. Dr. Kunal, we know that KMC, what, how to do, when to do, for whom it is to be done. Now, once we are doing the KMC, what are the ultimate goals, and how will you check that this KMC is proper and baby is getting benefited from this KMC? Dr. Kunal.
So the three basic components of KMC are that one is we should be giving a proper kangaroo mother care position to the baby. Second is breastfeeding should be ensured, and we should ensure that the baby is getting proper nutrition to these babies. Third most important component is that because of KMC, the baby is getting early discharge, and there is a proper ambulatory follow-up is being provided to the baby. The weight criteria which we follow is usually 15 gram per kg per day should be the weight gain in these babies. So if the baby is there is no upper limit, but at least minimum of 15 gram per kg per day of weight gain should be there. So proper positioning, proper nutrition, that will lead to proper weight gain and growth of the baby, as well as we should make sure that the baby gets a proper follow-up, and the KMC is being followed at the home of the baby also, whether by the mother or any of the relative, and it should be for as long as possible to the baby. Over to you, Manan.
Fine. So, Dr. Deepen, we are doing this KMC in and out for our ICUs. Are there any specific protocols by national or international bodies for starting and duration of this KMC? And second thing, once we are involving the parents and especially mother for KMC, how will you ensure the hygiene of this KMC provider? Dr. Deepen, please.
Yeah. So, if you consider that protocols for KMC, there are several protocols being laid by even World Health Organization. Even our National Health Mission has also provided a Navjat Sishu Suraksha Karyakram manual, which shortly summarizes kangaroo mother care in a nice way. Thus, even NNF, IAP have released several issues regarding use of kangaroo mother care. So now kangaroo mother care is known to everyone. Now, because of it has spread to even grassroots workers also, they have been aware and trained with regard to Navjat Sishu Suraksha Karyakram and its component, especially kangaroo mother care. Now, if you want to say that when we should initiate kangaroo mother care, as already we have understood and learned that it has to be started immediately after birth. So even in resuscitation also, we put the baby immediately on mother's abdomen and provide skin to skin care. So skin to skin care is one of the important and essential component of kangaroo mother care, which is started immediately after birth. With regard to the timing, because many times if you see the studies, several studies have said that maximum mean or median time of KMC hours per day usually is around 4 hours. But if you want that KMC to be optimally useful to the mother and newborn, the studies have said that at least 8 hours of KMC per day should be utilized for the baby. In such circumstances, we need to have extensive utilization of father or other relatives so that we can ensure more or at least more than 8 hours of KMC to up to maximum 24 hours so that it will give maximum benefit to the newborn. With regard to maintenance of hygiene, it is very important that in our social and cultural circumstances, many times it is very difficult to maintain hygiene of a mother because when she delivers a preterm baby, she might be sick also because of the other comorbidities like eclampsia, diabetes, postpartum hemorrhage, or antepartum hemorrhage. And because of this, mother would be in ICU and may not have enough resources for her hygiene also. In such circumstances, if you don't take care of these things, it might be possible that we might give infection to the newborn. So that we can have minimum things like there should be willingness of the parents or the mother should be in a good health, like she should not increase the risk of baby to get sick by infections. Mother can NICU or the KMC ward should have enough resources of hand washing. Mothers should have daily bath, so facility of washroom should be there for mothers as well, so that they can take bath daily and they should wear clean clothes. They should keep care of their fingernails. They should tie up their hair. In such way, we can ensure that the hygiene is ensured. It is also recommended that because of the cultural things, many mother they wear jewelry, they wear watches also. Sometimes sacred threads are also used. So if they are removed and they would optimally ensure that the babies will not be hurt during kangaroo mother care. So in such way we can maintain hygiene also. Yeah, Dr. Manan.
Great. So you need to have your unit policies, explain to your staff, plus explain to the relatives or caregiver. They should be in a good mental and physical health to provide KMC and not to provide infection.
Yeah.
Now the baby was with us. We have done excellently with KMC and everything. Baby gaining weight, no illnesses, and now baby is discharged. Dr. Hitesh, what is post-discharge KMC or KMC at home? How can we do it, and how can we follow it up with the discharge babies? Dr. Hitesh, please.
Yes. So once the baby is fit for the discharge according to our discharge criteria, and we are planning for the discharging this baby after detailed counseling, the parents, what need to be followed at home, and what we are expecting while during follow-up also. So we need to mention our follow-up visit plan. Like we need to follow the visit like once or twice a week in initial first few weeks till 37 weeks. Then every around once in a month till the baby weight gain is around 2.5 kg or 40 weeks of completion. Then every once in a 2 to 4 months till 3 to 4 months or 6 to 8 months. So each unit has a specified discharge policy or the visit should be mentioned, and that should be discussed with the parents also. While we are expecting the mother during the follow-up visit, we should have some checklist whether to ensure that whether mother is providing KMC properly or not, and whether the baby is gaining maximum or optimal benefits with the help of the KMC or not. So that checklist should include what is the weight gain pattern, what is the growth of the baby like anthropometry measures, and if the baby is not gaining weight properly, we need to understand what is the problem or where the obstacles are faced by the mother or the anything related to nutrition also. Another thing, while discussing with the mother, we need to ensure that technically the mother is providing KMC properly or not. Means for how much duration mother is providing KMC, what is the position of the baby, what is the any difficulty in establishing a breastfeeding while having a KMC, whether the baby is very much compliant while providing KMC or not. Ideally, we need to encourage the mother to continue the KMC till the baby attain at least 2.5 kg weight or 40 weeks of completed gestational age. So the winning criteria for the baby to from the KMC should be like if the baby is becoming very much fussy or becoming restless inside the while keeping the baby inside the KMC, that can be the indicator of winning the baby from the KMC. So all these things we need to understand. If the mother is facing some emotional problem, we need to support the mother emotionally also. We also need to emphasize the support of other family members as well as community to continue the KMC care at the home also. So all these things to be taken care of while dealing these babies during follow-up.
Great. So as we all know, KMC has three components. One is KMC position. Second is KMC or nutrition of the baby, and third is developmental supportive care. Once the baby is at home with mother, obviously KMC is important. Nutrition also we need to take care, and as KMC helps for breastfeeding, we need to gradually shift over to the breastfeeding when the baby is at home. And one thing that can help this mother after discharge is we can form a foster group of the mothers who are doing KMC at home, and they can share their ideas, they can share their problems, and then baby ultimately can get benefited. So we have all seen about KMC, and this is now era of developmental supportive care. Dr. Snehal, can you elaborate what are the developmental supportive care measures in NICU during our day-to-day practice, and how can we apply them on bedside?
Yes. So developmental supportive care is, most important for neurodevelopmental outcome of the babies, and it should be an integral part. So what are the developmentally supportive care we should be providing to the baby, starting from the position of the baby? As we discussed, where there should be a proper nesting position, and the baby should feel like a warm, and the nesting. In the nesting, the baby should be in a comfortable position, so that that is a neurodevelopmental friendly position, we say. So that should be ensured. The second most important component of developmental supportive care is in KMC. So we have all known the benefits of KMC and what are the importance of giving KMC to the babies. The third is cluster care of the NICU babies. So handling the babies when needed, avoiding unnecessary touch, unnecessary noxious stimulations to the baby should be done. Excessive noise should be avoided in the NICUs. as we are treating the PPHN babies, we do take care of the darkness. We should not prick the babies. We do take care of increase in the peer pressures of this PPHN babies. This all should be done in the NICU to have a good neurodevelopmental outcome of these babies. Circadian rhythm of the light and darkness should be maintained so that that is good for the development of the baby. Swaddling should be ensured. I do stress upon them when the mothers do come. We involve not only in the KMC but for the early stimulation therapies as well. So when my sisters are giving massage, I do as a mother to give a oromandibular stimulation to the baby or oromental stimulation to the baby, giving a light massage to the babies when they are giving for the KMCs, talking to the babies. This is kind of auditory stimulation in all holistic aspect. We can ensure the proper neurodevelopment of babies by doing all this mandal of developmental care to these babies.
Great. So KMC is only just a single part of the developmental supporting care. We need to take care of the day-to-day activities. The environment should be proper, soothing, sleep should be maintained, and we need to involve the families for the baby care. Dr. Poonam, there are some skepticism about KMC. That do you think it increases the risk of preterm complications, septicemia, or other any adverse outcome related to the KMC and its procedure?
No, there are no risk factors for KMC. Only contraindication is baby should be hemodynamically stable. Otherwise, there are no contraindications for giving KMC. In fact, studies have shown that KMC reduces the risk of sepsis as well as pneumonias in the preterm baby. So it prevents more complications than it does any kind of complications. So I don't think it increases sepsis at all.
Right. So in single sentence, KMC is not having any complications, and without fearing septicemia or other thing, we can freely give KMC. Dr. Snehal, tell us about family-centric NICU. What is that?
So, what is family-centric neonatal care? As I've already discussed, while doing antenatal counseling, as at that point of time, we can involve the family as a team member. We can ensure the family. We can take care of the family priorities, family restrictions, some ritual beliefs as well. So at that point of time, we can motivate the parents, motivate the mother to come for the KMC. We can ensure that they are learning the feeding of the baby well. When we are discharging this baby, we should ensure that they are in the proper environment to be taken care at the home. So before going from an ICU to the home, that should be some step down type of an NICU where the mother and father can be there with the baby, and we can explain all temperature management, feeding policies, how to take care of how to take care of the positioning of the babies, monitoring the baby's oxygen level and all when it is needed. So all should be explained to the parents, and that's called family centered care.
Right. So as I told my all staff members, that parents, mother, father are not visitors. They are the core team member who will help us in the baby care. We need to involve them, and we need to have their support to ultimately have developmentally good outcome. Now, as Dr. Snehal said, the family-centered NICU, Dr. Deepen, in terms of Indian logistics and finances, how feasible is that thing here, and what should be the infrastructure of such family-centered NICU?
So we must have read the recently published article of immediate kangaroo mother care, which was published in May 2021 last year. In that study, all the areas which were included were from the lower middle income countries like Ghana, India, Delhi. I think Delhi was the center utilized for this study. In this study, they modified the infrastructure in little bit, and they provided a cot to the mother, reclining chair to the mother, so that they also made some changes in the protocol in terms of involving the gynecologist and neonatologist together with nursing care. So it is not difficult. It is possible. Even WHO says that if you want to involve a family-centered care, especially kangaroo care, or you can say kind of a mother NICU, it may not be so much difficult to implement. Now, you must have said that because the newer NICUs are coming, they have better facility, and even the family rooms can be designated if mother or father cannot stay with the baby. So nearby area, if there are family rooms, they can come frequently to take care of a baby. And now, like immediate kangaroo mother care, in which even mildly unstable babies like who need minimal respiratory support can also be taken care by in the centers. Now, this is a picture of our NICU in a step down NICU in which we have kept beds. You can remove one bed and keep a written warmer beside to the cot, in which so that mother can sleep with the baby. Reclining cots will help provide KMC and provide comfort to the mother. Simultaneously, there are oxygen airports, suction ports also with enough electric supply also, so that secondary level of care can now be ensured in our country by utilizing the existing resources.
Yes. So the finances and logistics are not the concern. It need to be our onus that we with the facilities we have, we need to create an environment and ICU infrastructure that provocates the family-centric care. The last thing I want to ask Dr. Hitesh is, are there any contraindications to give KMC to the preterm babies?
No, as rightly mentioned by Dr. Kunal, that there is no absolute contraindication of providing KMC. But because if the baby is extremely preterm or baby is sick, critically ill, sometimes we are not able to start the KMC immediately or in early days. But as soon as the baby becomes stable, we need to start the KMC. Sometimes because of some medical illness to mother or some physical problem or some other issues or some infectious disease that have propensity to transmit transmission to neonate or newborn baby, then we need to think that we cannot promote the KMC during that infectious time period. But once the mother is well, and we can promote the KMC as soon as possible.
Right. So there are no contraindications. We can give KMC in each and every preterm. Just to have a caveat that if the baby is having anatomical issues with the respiratory tract and KMC positions increasing the respiratory distress, in that case, we should be avoiding KMC. Otherwise, in all the cases, with hemodynamically stable babies, we can give the KMC. So with that, I want to stop our discussion here, and I just want to convey that KMC is extremely impactful, and looking at the broader picture, the big impact, developmental supporting care with parents' embrace is the most powerful strategy to deal with this huge burden of preterm with us, and to provide them the ultimately good neuro intake outcome. At the outset, I thank the organizers and all the wonderful panelists to make this session interactive and informative. And thank you so much for the valuable time provided for this World Prematurity Day celebration. Thank you. Over to you, Prashant bhai.
Yeah, thank you so much to all the panelists and moderator Manan. It was really a wonderful discussion. Before we end today's talk, I'll just like to present and launch our Neo Blaze 3. Thank you, Dr. Kunal Iyer, for beautifully designing this. And this is our third bulletin of the year, which not only includes all our neonatal Pathshala programs, but also includes wonderful articles to read, as well as the brief report of our West Zone Pedicon, West Zone Neocon, the memories. So I'll be releasing this today, so you all can actually see the photographs and everything of our conference. Thank you so much. And now I request Deblina. Deblina, can we have the certificates? This was such a huge topic that we didn't realize that we crossed 1 hour, and still the discussion was going on. Deblina? Uh, so on behalf of NNF Gujarat, we are thankful to our panelists who have actually spared their time, and they deserve a certificate of appreciation. So thank you so much, Dr. Snehal Patel, for being a faculty, Dr. Hitesh Patel, Dr. Dipen Patel, Dr. Kunal Ayya, and thank you so much, Manan Parikh, for moderating the panel discussion so well. Thank you so much, everyone. Yeah, we can leave the meets now, and thank you.
Thank you, everyone. Thank you.
Thank you.
So much.
Yes, sir.
Thank you so much, all. We are closing here for